Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. I noticed that the insurance companies agree nowadays frequently to perform PAP tests, and many gynecologists are enthusiastic with performing this technique, and this is a good thing in the way of prevention of cervical cancer. And the problem that the interpretation of PAP test result by the gynecologist is not clear. I mean that referral to colposcopy by the gynecologist is not well established or not well settled for many doctors. So in this presentation, I would like to show you what are the indications of referral to colposcopy if you see a PAP test result. You know, colposcopy is performed based on the results of PAP test mainly, and also for positive patients with HPV, DNA, positive visual inspection after acetic acid application, unexplained persistent infection or bleeding, or follow-up of some cases treated for cervical cancer or precancerous lesions. Regarding PAP test, I would like to highlight the Bethesda classification. If you see the result with high-grade squamous intraepithelial lesion, high cell, this is a clear indication for colposcopy, and you have to be resistant with the companies to refer your patient to colposcopy. Another indication is atypical glandular cells, and if you see any atypical glandular cells, this is an indication for colposcopy. Regarding other cells like ascus, which is atypical squamous cells of undetermined significance, actually it is of undetermined importance or insignificant importance, but if it is persistent for 1 year or more, this is an indication for colposcopy. So ascus per se is not an indication for colposcopy, but persistent ascus for 1 year or more, this is an indication for colposcopy. The same applies for atypical squamous cells that cannot exclude high cells. If persistent after 1 year, this is an indication for colposcopy. Otherwise, don't refer patients with ascus or low cell to colposcopy. The same applies for ascus and low grade squamous intraepithelial lesion. If they are associated with positive HPV, this is an indication for colposcopy. So you have to stratify your patients into clear indication for laparoscopy, which is high cell and atypical glandular cells, patients with clear after some conditions, which are ascus and low cell. This is an indication after 1 year persistence or positive HPV. The last indication based on Bethesda classification is atypical squamous cells that cannot exclude high cells. So you have to consider it as high cell. So high cell or cannot exclude high cell, this is a clear indication for colposcopy. Regarding PAP test, also, if you find normal PAP test, but the cervix is clinically suspicious or naked eye examination with bleeding on touch or postcoital bleeding, postmenopausal bleeding, this is an indication for colposcopy. And lastly, if you find persistent inflammatory or the result of cytology is unsatisfactory, cytology despite proper treatment, especially with high-grade, high-risk patients like patients with suspicious cervix on clinical examination, these are indications. So if you consider this slide in your mind, you can guide your patient to do colposcopy in a short way. And here is one of the two examples I explained to you to show the importance of good selection of cases. Here is a case of nulli gravida with recurrent vaginal infection, and the PAP test result is high cell. High cell with increased nuclear cytoplasmic ratio, nuclear abnormalities of high-grade dysplasia. So this case is an indication for colposcopy, as I told you based on Bethesda classification. So if you look to the patient after with colposcopy, you will find that the cervix is very friable with bleeding on touch. And after removal of the blood clots and application of acetic acid, there are some acetoid areas with mosaic and punctations with abnormal vasculature with excessive bleeding on touch from the cervix. And of course, we apply Lugel's iodine, which is Seller's iodine test. Also, the same iodine negative areas, which is positive test with sharp border. And on performing multiple bunch biopsy forceps, multiple biopsies using bunch biopsy forceps, you will find excessive bleeding, and the cervix is very friable. And this is not assuring sign when you are doing colposcopy. So I immediately buzzed into the decision of doing large loop excision of the transformation zone as a one-stop management of or cervical lesions when you are in clinical suspicion regarding this result of this cervix. And after removal of the transformation zone with the loop and coagulation of the bed with a ruler ball electrode to stop any bleeding, the cervix appears like this view. And this is the end of this procedure. And if you look to the results of the cytology, you will find of the histopathology, you will find the histopathologist told you that the case has CIN2, and this is a suspicious cervix. So clinically suspicious cervix, cytology, high cell, decision of large loop excision by the colposcopist after doing multiple bunch biopsies, but with excessive bleeding due to friability of cervix that favored large loop excision, and the result is CIN2. So don't ignore the high cell in your cases. This is another example. A patient is para-1 plus 0 with genital warts, positive HPV 16 swab, and the cytology is ascus. So ascus alone is not an indication for colposcopy, but ascus with positive HPV is an indication for colposcopy. So don't forget the first slide of selection of the cases for colposcopy. And of course, ascus appeared as enlarged polygonal sharp cells with prominent nuclei and granular cytoplasm and minimal nuclear hyperchromatism and irregular chromatin distribution and some abnormal mitotic figures. And this is ascus with positive HPV. So this is an indication for colposcopy. And you can see in this short video the appearance of this cervix on colposcopy after application of acetic acid. There are acetoid areas with, again, with punctations, mosaic, abnormal vasculature, immature metaplasia, some cervical ectopy, and inflammatory picture, in addition to some warts in the vaginal fornices. And these are these findings go with positive HPV 16 type in this patient. And this is the cervix with immature metaplasia, and as I told you, abnormal transformation zone with mosaic and punctation with sharp borders. And of course, we have to do Schiller's iodine test and to see the cervix after application of iodine, to see the iodine negative areas with sharp borders. And this is cervix after application of Lugel's iodine. And you can see the iodine negative area with the whole ectocervix appears with few dots or punctation due to colpites, and the abnormal transformation zone and abnormal warts in the vagina are seen also as iodine negative areas, and also some warts. Here is a cervix of inflamed cervix's appearance. And again, large loop excision of the transformation zone was done in this case because of high titer of HPV-16 with ASCOS, and the clinically suspicious cervix, and the warts are seen in the vagina, and this abnormal area is suspected to be HPV or CIN1 according to the studies. So this is excision of cervix with large lobe excision, and again coagulation of the bed with a ruler ball electrode to stop any bleeding, and this is the final appearance of cervix after doing the large lobe excision and coagulation of the bed using the ruler ball. And this is one-stop management of such a case. And the biopsy results is CIN1. So these are two clear indications for colposcopy, and the results of colposcopy were positive. The histopathologic results supported this finding. So in conclusion, please put colposcopy in your mind in certain indications with abnormal back test, and thank you very much.